A burn injury occurs when the tissues of the body are damaged by a heat source. The source may be thermal, chemical, electrical, or radiation. The effects of burns are influenced by the temperature of the burning agent, the duration of contact time, and the type of tissue injured. The most current data suggests that the United States has the 10th highest fire related deaths of the industrialized nations. The highest fatality occurs in children ages 4 and younger and adults over 65 years old. Burn injuries continues to occur more frequently to those of a lower socioeconomic background, those with a history of substance abuse and mental illness. Scald injury and flame are the two most common types of burns, with scalding being most prevalent in children under age 5, and flame is the most prevalent in other groups. Thermal burns are the most common types of burn injury. Two factors that determine the depth of a thermal burn are the temperature to which the skin is heated and the duration of contact to the heat. There's chemical burns, which usually occur in the home and in the industrial setting. Radiation is the least common type of burn injury. The extent of an injury is dependent on the type, the dose, and length of exposure. Sunburn is the most common type of radiation burn you will see in the healthcare setting. It is characterized by erythema, edema, blisters, and pain. The patient should be taught to take precautions to protect the skin from sunburn. For example, staying out of the sun between 10 a.m. and 2 p.m. because UV rays are at 80% level during those times, even on a cloudy day. Use an umbrella or wear a long sleeve, or even wearing a sunshade. Smoke and inhalation injury usually results from breathing in noxious chemicals or hot air, which causes injury to the respiratory tract. Upper airway injury is usually caused from burns or inhalation of hot air, steam, or smoke in the mouth, the oropharynx, or the larynx. Burns to the upper airway can be significant and occurs rapidly. These burns can cause difficulty with breathing. For example, burns to the neck and chest can make breathing difficult due to edema and constriction of the burn eschar. Be aware that burns to the upper airway can cause mechanical obstruction and cause airway emergency. In lower airway injury, inhalation of smoke and other chemicals can cause injury to the alveoli, the bronchioles, and the trachea. To assess for lower airway injury, the nurse should look for facial burns, cinched nasal air, hoarseness, painful swallowing, darkened nasal and oral membranes, carbonaceous sputum, a history of being burned in an enclosed space, and if the person's clothing is burned around their neck and chest. For electrical burns, these are caused from electrical shocks and can cause cardiac issues, for example, ventricular fibrillation. It can cause delayed cardiac arrhythmias, or a cardiac arrest may also occur within the first 24 hours after the injury. It can cause damage to the nerves and vessels, leading to a loss of oxygen supply to the brain and tissue, and eventual death. An electrical burn can also cause injury or cause bones to be broken depending on how severe the electrical injury is. So it is important that you assess for broken bone in a patient who has an electrical burn. The severity of a burn injury is determined by the depth of the burn, the extent of the burn in the percent of total body surface area, the location of the burn, and the patient's risk factors. The depth of tissue damage is classified as superficial, superficial partial thickness, deep partial thickness, and full thickness. It is difficult to initially determine the depth of an injury because burn injuries will only be evident within the first 24 to 72 hours, and therefore it's important that continuous assessment is done. Superficial burns, otherwise called first-degree burn, involve the top layer of the skin or the epidermis. It is usually erythematic or red in color. It is hypersensitive, easily blanches on pressure with pain and mild swelling, and there are no vesicles or blisters. Superficial partial thickness burn or second degree burn involve the epidermis and the dermis. These burns tend to be very painful because of the nerve endings present in the dermis. Superficial partial thickness burns are pink, red in color. They have fluid-filled vesicles that are red, shiny, and these may rupture. It blanches easily and is mild edema. Capillary refill on burn areas remains normal, and healing usually takes place within 1 to 2 weeks. Deep partial thickness burn or third degree burn involves the entire epidermis and deep layers of the dermis. So in this case, all epidermal and dermal structures are destroyed, including hair follicles, sweat glands, and nerve ending. There will be little or no skin reproducing cells remaining to regenerate new skin, and full thickness burns do not heal spontaneously. In this case, the patient will require grafting. The partial burn injuries usually present with a dry, waxy white and a leathery feel. There may be blisters that are open or closed. This leathery burn tissue is also called an eschar. Sometimes the color may vary as light pink or cherry red, mottled or pale in the center, edema, sluggish, or no blanching. Close monitoring is required of the wound to determine the progression from deep partial thickness to full thickness injury. Full thickness burn, the entire epidermis and dermis is damaged. All structures including hair follicles, sweat gland, nerve ending, fat muscles, and bones are involved. The patient will often not feel pain or touch because of the damaged nerve. They are very dry and leathery to the touch, also known as eschar, as we previously described. It has a pale color, white, brown, tan, black, or charred. There is no blanching, no pain in the center of the wound, but may be sensitive to pressure. Full thickness burns do not heal by themselves. Therefore, it will require excision and skin grafting because all of the elements required for repair has been destroyed. The total body surface area is expressed as a percentage of total body surface area. It is essential in guiding adequate fluid resuscitation and treatment. The Lund-Browder chart is most widely accepted and is considered most accurate in determining the percentage of total body surface area burn. It takes into account the patient's age in proportion to relative body surface area size. The rule of nines is the most commonly used method because it is easily remembered and is considered efficient for initial assessment of the adult burn patient. Irregular or odd-shaped burns, such as the fingers and hand, is 1% of the total body surface area. With this method, the adult body surface area is broken down into 9% or multiples. The division is modified in children because of the large surface area in the infant and children's head, and the smaller surface area of the lower extremities. Using the rule of nines is adjusted for use in children because of the difference in body proportion between children and adults. The Lund and Browder chart is corrected for age. The severity of the burn will depend on the location of the burn. Burns to the face and neck, chest and back may inhibit respiratory function because of mechanical obstruction secondary to edema or the eschar. Burns to the hands, feet, joints, and eyes makes it difficult for the patient to practice self-care and may affect later functions such as ADL. Managing burns to the hands and feet is not easy because of the superficial vascular and nerve supply system that needs to be protected while the burn wounds are healing. Burns to the nose and ear are highly susceptible to infection because of the poor blood supply to the cartilage and because of being highly exposed. Burns to the buttocks or perineum area are also highly susceptible to infection from urine and fecal contamination. Circumferential burns to the extremities can cause circulation problems distal to the extremities. Compartment syndrome. Direct heat damage to the muscles, swelling, and or pre-burn vascular problems can cause compartment syndrome. And what is compartment syndrome? This is when excessive fluid buildup of pressure occurs in an enclosed muscle space in the body. It usually occurs from bleeding or swelling after an injury, and it impedes the flow of blood to and from the affected area. The elderly and the young are at the highest risk for burn injury. Individuals with a pre-existing heart, lung, and kidney disease will have a poor prognosis for recovery from a burn injury. Those with diabetes or peripheral vascular disease will have a high risk for poor healing. Patients who are alcoholics, who abuse drugs, and who are malnourished are usually at risk for poor healing, at risk for getting burn injury, and will have poor prognosis for recovery. Patients with fractures, head injury, and other trauma inhalation are at risk for burn injury. An overlapping of care exists from one phase to another. For example, although the emergent phase is seen as beginning in the emergency room, it can often begin in the pre-hospital phase depending on the skill level of the paramedics at the scene. Planning for the rehabilitation phase begins on the day of the burn injury or admission to the burn center. Formal rehabilitation begins as soon as functional assessment can be performed. Wound care is the focus of the acute phase, but it can also take place in the emergent and rehab phase. The emergent phase is the time required to resolve immediate problems resulting from injury. Hypovolemic shock and edema formation are the primary concerns in this phase. This phase can last up to 72 hours. The emergent phase will end when fluid mobilization and diuresis begins. Hypovolemic shock occurs when large amounts of fluid move out of the blood vessels into the interstitial spaces because the capillaries have become permeable due to vasodilation, and this takes place at least 20 minutes post-burn. Fluid and electrolyte loss occurs when the capillary walls become more permeable. Vital substances such as sodium, plasma protein, and water and potassium move into the interstitial spaces and other areas. The two electrolytes of most importance or concern during the burn shock phase are potassium and sodium. Initially, hyperkalemia may result because of the release of potassium from the cells into the vascular space. As fluid continues to shift, potassium and sodium begins to leak out of the intravascular spaces, and hypokalemia and hyponatremia may result. Replacement therapy is initiated as warranted. Other sources of fluid loss include third spacing, and third spacing occurs when fluid moves to areas that normally have very little fluid, for example, a burn blister, exudates, and edema in unburned areas. Then there is insensible loss. Insensible loss is evaporation from the lungs, or large bare naked areas. Evaporated fluid that is lost from the burn wound should be documented and accounted for, as this could be in excess of 5 liters per day. So signs of hypovolemic shock to look for includes a decrease in blood pressure and an increase in heart rate. If hypovolemic shock is not corrected, it can lead to refractory shock and death. Burn shock is the combination of movement of fluid and hypovolemic shock. It is presented by the volume of fluid depletion, low cardiac output, and increased systemic vascular resistance. The burn patient will oftentimes experience shock as a result of hypovolemia. When full thickness burn and partial thickness burn takes place, the nerve endings in those areas are damaged, and so initially the patient will not experience any pain. Burns that are of superficial to partial thickness are quite painful. Partial thickness burns usually present with blisters that are filled with fluid and proteins. The patient with large burns oftentimes develop a paralytic ileus, which is absent or decreased bowel sound. This is not frequently seen in burn patients anymore because of early interventions with enteral feeding. Patients with major injuries who require large amounts of fluid for resuscitation may develop abdominal compartment syndrome secondary to large volumes for resuscitation. Heat loss, anxiety, or pain, which is caused by chilling, may result in shivering. The large burn wound causes heat loss because it's difficult for the body to regulate temperature without the skin. A burn victim might be able to answer questions initially upon admission or until intubation if called for. The burn victim will be frightened, scared, and will need to be calmly reassured by giving simple explanation of what to expect as care is provided. Hypoxia associated with smoke inhalation is one of the main causes for loss of consciousness and the altered mental status experienced by the burn victim. Other causes may be head trauma, substance abuse, pain medication, or excess sedation. Upper airway distress is possible with or without smoke inhalation. The three most important areas of concern with respiratory complications include carbon monoxide poisoning, upper airway injury, and lower airway injury. Burn victims with a history of coronary artery disease or COPD are at an increased risk for complications. Therefore, fluid resuscitation should not be too vigorous. They should be monitored closely for heart failure or pulmonary edema. Pneumonia is the leading cause of death in patients with inhalation injury from major burns. Carbon monoxide poisoning is the cause of most fatality occurring in burn cases. CO levels that are above normal can be fatal, resulting in tissue hypoxia. Characteristic symptoms of carbon monoxide poisoning include headache, confusion, nausea, dizziness, vomiting, and dyspnea. A patient who has CO poisoning should be treated with 100% oxygen by mask until levels are appropriate. Hypovolemia can lead to decreased blood flow to the kidneys, causing renal ischemia. This can seriously injure the kidney. Myoglobin from red blood cells break down in cases of full thickness burns and electrical burns are released into the bloodstream and cause blockage to the tubules. Anemia may result from the loss of red blood cells. Inadequate fluid resuscitation and blood flow can result if myoglobin and hemoglobin block the renal tubules and result in renal necrosis. Compartment syndrome, fluid seeping from the intravascular space into the interstitial space, causes a rise in pressure within the tissue and confines, swelling inside the muscle compartment. Affected extremities should be elevated, and pulses in both burn and unburned extremities should be assessed and compared orally. The patient with compartment syndrome will manifest symptoms such as progressive diminishing of their pulses, numbness, tingling, and excruciating pain with flexion and or extension regardless of being medicated. And this is a medical emergency. An eschorotomy is a surgical incision that is done in cases where there is circumferential burn to the extremity and there is a risk for developing compartment syndrome. In full thickness burn, the eschar acts as a tourniquet, and so as fluid resuscitation continues, vascular compromise may result. The incision is made through the eschar and into the fatty tissue to relieve the pressure. A fasciotomy is done when the burn has extended into the muscle and is done mainly to patients who sustain electrical burns and has compartment syndrome. The incision is made through the fatty tissue and muscle to allow for expansion of the muscle compartment. Major organs susceptible to complications from burns are the cardiac, the respiratory, and the urinary system. Burn shock is the greatest risk to a patient with major injuries. The patient will experience a combination of distributive and hypovolemic shock. In the cardiovascular system, complications will include hypovolemic shock and dysrhythmias. Inadequate fluid resuscitation can cause the burn victim to go into shock, including hypotension, tachycardia, reduced urinary output, and altered mental status. The patient can end up having multi-system organ failure or death if fluid resuscitation is inadequate. Deep circumferential burns and edema formation can lead to an impairment of circulation to the extremities. The way this works is the deep burns and the edema acts as a tourniquet, which is, if left untreated, can cause ischemia or paresthesia and necrosis. Sludging occurs because of fluid loss. The blood viscosity increases, skin structures with small capillary systems are damaged and result in impaired microcirculation. This is corrected by adequate fluid replacement. From the onset of the burn until the patient is stabilized, nursing management predominantly consists of airway management, fluid therapy, and wound care. Early intubation is initiated during airway management and is done to avoid the need for emergency tracheostomy after respiratory problems has been identified. Burn injuries above the glottis that involve the face and the neck will require intubation within 1 to 2 hours after the burn because swelling can occur within minutes to hours of injury. The intubated patient will be placed on ventilator support with oxygen concentration that is based on the client's ABG values. Unless there is serious inhalation injury, the patient may be extubated within 3 to 6 days after the burn injury once the edema has subsided. If the patient does not require intubation and there is inhalation injuries, the patient should be administered 100% humidified oxygen as ordered and should be placed in a high Fowler's position unless contraindicated. The patient should be encouraged to cough and deep breathe at least every hour, reposition the patient every 1 to 2 hours, and provide suctioning and chest PT as ordered. If the patient goes into severe respiratory distress, intubation and mechanical ventilation may be reinitiated. Fluid resuscitation, the overall goal is to maintain tissue perfusion and organ function while at the same time avoiding potential complications of inadequate or excessive fluid resuscitation. Burns that are 15% or more of the total body surface area will require at minimum 2 large bore IVs. And this is because the patient will require large volumes of fluid replacement. Burns that are greater than 30% will require a central line for fluid and drug administration and blood sampling. Arterial lines should be considered if frequent ABGs or invasive blood pressure monitoring is required. Usually an indwelling urinary catheter is placed in the bladder to monitor output as a way of determining the effectiveness of fluid resuscitation. In order to identify the fluid needs of the burn victim, the Lund-Browder chart is used to assess the extent of the burn, and then the Parkland-Baxter formula is used to estimate the patient's fluid resuscitation needs. The Parkland formula is weight-based and requires 4 milliliter lactated ringers per kilogram of body weight multiplied by total body surface area, the percentage of the total body surface area. Half of the total volume of fluid is given in the first 8 hours post-burn, and the remaining half is given over the next 16 hours. Resuscitation usually begins from the time of the burn injury. Solutions that are usually administered are usually crystallite solutions such as lactated ringers, or colloids such as albumins, or a combination of both is usually used. It is recommended that colloids such as albumin at 5% should be administered 12 to 24 hours post-burn when the capillary permeability returns to normal. Normal saline is usually started at the pre-hospital phase. Wound care. After ensuring that the burn patient has a patent airway, effective circulation, and adequate fluid replacement, the priority should then become wound care. Debridement is a process used to remove necrotic skin from the patient. The wound should be cleaned and debrided daily, and apply antimicrobial ointments and dressings as ordered. The process can be done by the RN and the unlicensed assistive professional. Ensure that accurate documentation and record of healing and any signs of infections, such as fever or any change in wound appearance, is recorded. For the child with burn injury, ensure that the child's tetanus immunizations are current. When providing wound care, always wear your or don your personal protective equipment around the patient with open burn wounds. Non-sterile disposable gloves should be used when removing contaminated dressings and washing the wound. Sterile gloves should be used when applying ointments and sterile dressings. Try to keep the room at a temperature of approximately 85 degrees to prevent shivering. During the emergent phase, nursing care and management is very critical. Special care should be given to the face, and so we want to ensure that the eyelashes are not curled inwards. We want to provide moisture for their eyes and keep pressure off their ears, so no pillows should be allowed for their burn ears. We want to elevate the patient's head using a rolled pillow under their shoulder, and we want to prevent contracture by using a rolled pillow to hyperextend their neck. We're going to elevate the patient's burnt arms and hand on pillows to reduce edema. The perineum should be kept clean and dry, and we want to provide pericare at least once or twice per day. Lab values should be monitored very closely, and you want to collaborate with PT to provide range of motion exercises during dressing changes and throughout the day. In the burn victim, 5% human serum albumin is used in cases of patients with hypovolemic shock. It increases plasma colloid osmotic pressure and aids in rapid volume expansion. The nurse should monitor for rapid fluid overload and should look for signs and symptoms such as chills, fever, or itching. Analgesics are ordered to promote patient comfort. IV medication should be given early because it has a fast onset, and PO medication will take a long time to take effect. In addition, because the GI tract of the burn patient is slowed down or impaired because of shock and paralytic ileus. And 3, a burn and edematous area of the patient does not adequately absorb IM injections. The medication will pool in the tissue, hence, when fluid begins moving, the patient could become overdosed from the interstitial accumulation of IM medication. Monitor for respiratory depression when giving large doses of pain medication. Analgesics requirements should be reevaluated as the patient's needs may change and they may become tolerant over time. Opioids are the drug most frequently used for pain control in the initial phase. Sedatives, hypnotics, and antidepressants can be given with the analgesic to control the emotional distress and aid with sleeping. Remember that the analgesic requirement will be different for each patient, and the pain level experienced by the patient may not correspond with the extent and the depth of the burn. After cleansing a wound, an antimicrobial agent is applied and covered with gauze. Systemic antibiotics are not routinely used to control burn wound flora because the burn eschar has little to no blood supply, and so little bit of antibiotic will be delivered to the wound. Additionally, systemic antibiotics will increase the chance of developing multi-drug resistant organisms. Systemic antibiotic therapy should begin when there is a diagnosis of sepsis or other infections such as pneumonia. Antimicrobial agents that are typically used include Silva's nitrate solution, mefenide cream, or Silvadene. We want to monitor the patient for signs of sepsis as it is the primary cause of death in the patient with major burns, and sepsis may lead to multi-organ dysfunction syndrome. In cases of fungal infections in the mouth or genitalia as a result of systemic antibiotic, mycostatin mouthwash should be administered. Yogurt or lactobacillus may be administered to reintroduce the normal flora. Early nutrition therapy helps to decrease complications and mortality. It promotes burn wound healing and minimizes the negative effects of the hypermetabolic state in the burn patient. During the hypermetabolic state, the core temperature of the patient will go up 50 to 100% above normal. In the acute phase, wound healing and closure, pain management, nutrition, and infection prevention are the priorities. It begins with the mobilization of extracellular fluid and subsequent diuresis, and concludes when partial thickness wounds are healed and or full thickness burns are covered by skin grafts. In the acute phase, diuresis from fluid mobilization begins and the patient is less edematous. It begins 48 to 72 hours after a burn injury, wherein the capillary membranes are no longer permeable and fluids that usually causes edema now begins to move back into the vessels, resulting in an increase in blood volume which increases renal flow and results in diuresis. Hemodilution will result in low hematocrit levels. Potassium will be reduced as it moves back into the cells or is excreted in the urine. Bowel sounds will return, and healing begins as white blood cells surround burned wound and phagocytosis occurs. It is important to pay attention to all the fluid going back to the intravascular system, as this can result in fluid overload. Also, be aware that although the fluid shift may have been resolved at this stage, the patient continues to be acutely ill. During the acute phase, necrotic tissue will begin to slough, fibroblasts will set in place collagen precursors, which then forms granulation tissues. Partial thickness burns will heal from the edges and the dermal bed. Eschar and full thickness burns must be surgically removed and skin grafts applied in order for healing to take place. Healing time and length of hospitalization are lessened by early excision and grafting. For partial thickness wounds, the eschar separates soon after injury. The eschar is removed and reepithelialization takes place, presenting as a red-pink scar tissue. Epithelial buds formed at the hair follicle and glands in the dermal bed and eventually closes the wound. Healing is spontaneous and occurs within 10 to 21 days. Full thickness eschar, in these cases the margins take a longer time to separate, and this causes full thickness burns to require surgical debridement and skin grafting in order to heal. Mild confusion, chills, loss of appetite, malaise, hypothermia, hyperthermia, bradycardia, and low urine output are some signs of infection that might be observed in the burn patient. The white blood cell counts is usually between 10 and 20,000. The patient has become immunosuppressed after the burn. Sepsis in the burn victim is caused by a gram-negative bacteria, which puts the patient at risk for septic shock. If sepsis is suspected, immediately collect cultures from all sources that has possibility of causing the infection. Example, the IV site, the burn wound, blood, urine, sputum, the oropharynx, and the perineal area. Treatment will be immediately initiated with the antibiotic appropriate for the suspected flora. Once the culture and sensitivity is collected, the same antibiotic being used for the patient may be continued or changed based on the result. At this stage, it is important to monitor the patient's vital sign and their mental status. The musculoskeletal system of the burn patient is prone to complications in the acute phase. This is because as the healing process proceeds and the scar tissue forms, the skin becomes less supple and pliant. The patient may have limited range of motion, resulting in joint contractures. Also, the patient prefers to assume a flexed position for comfort because of pain. Have the patient stretch and move the burned body parts as much as possible. It is super important that the physical therapist and the occupational therapist are involved. Consult with the physical therapist, occupational therapist personnel about proper positioning and splinting to prevent or reduce contracture formation. For the GI system, a paralytic ileus can be caused by sepsis. Diarrhea may be caused by antibiotic use or enteral feedings. And constipation can be a result of opioid use, decreased mobility, and a low fiber diet. Curling's ulcer, otherwise called a stress ulcer, is an acute gastroduodenal ulcer caused by the stress response to decreased blood flow to the GI tract. Gastric acid secretions is increased with this condition. The esophageal duodenum mucosal barrier is now disrupted. To prevent Curling's ulcer, the patient should be fed as soon as possible after a burn injury occurs. The main focus of care in the acute phase includes wound care, excision and grafting, pain management, physical and occupational, and nutritional therapy. There are three types of debridement. Mechanical debridement is cleansing and removal of loose necrotic tissue using tweezers and scissors. The process is usually aided by the removal of gauze dressings and hydrotherapy. Hydrotherapy is frequently used in most burn centers because it thoroughly cleanses the wound using water to remove necrotic tissue and topical agents during dressing changes. Enzymatic debridement includes application of an enzyme which breaks down the protein. It hastens eschar separation and wound healing. Enzymatic debridement is often reserved for patients with deep partial thickness wound where signs of healing are evident. Enzymatic debridement is also considered in patients with full thickness burns who may not be candidates for surgery. In the event enzymatic and mechanical debridement is not effective, a surgical debridement may be necessary. In a surgical debridement, full thickness burn wounds, necrotic tissues are usually excised, followed by application of split thickness autograft skin. Early excision and grafting of burns decreases the length of hospital stay and increases the survival rates of these patients. Wound care is a clean process and not a sterile process. During the debridement phase, cleansing the wound is done with soap and water or gauze moistened with normal saline to help with gently removing old antimicrobial agent and necrotic tissues or dried blood. In the event the patient requires skin grafting, it is necessary to protect the skin graft with the same greasy gauze, followed by a saline moistened gauze in the middle and a dry gauze on the outside. For facial burns, unmeshed sheet grafts are used. It is left open to allow the formation of blebs. Blebs prevent the graft from permanently attaching to the wound bed. A tuberculin syringe is used to aspirate the exudate. This process can only be performed by a trained professional. Managing a full thickness burn involves early removal of the necrotic tissue, followed by application of the split thickness autograft skin. A cultured epithelial autograft is a technique that is used only in the most severely burned patient where there is no other alternative. It is grown from biopsies obtained from the patient's own skin, usually from an unburned part of the patient's body, and it is used in patients with a large body surface burn area or those with limited skin for harvesting. Artificial skin or Integra is used in life-threatening full-thickness burns. It is able to replace all functions of the skin and has both dermal and epidermal elements. Burn pain management is a continuous process throughout the emergent phase and throughout the acute phase, all the way into the rehab phase. The pain experienced by the patient includes continuous background pain, and this is the underlying pain from the primary injury that is continuous and ongoing. IV infusion of opioid on a continuous basis can provide a steady therapeutic level of the drug while the pain is unrelenting. If IV opioid is not used, twice a day slow release opioids are used. All efforts are made to transition to oral medication as tolerated. Breakthrough pain is another type of pain experienced by the burn victim. This is related to specific episodes associated with activities of daily living, such as walking or dressing changes. The other one is treatment-induced pain. This is associated with therapeutic activities such as wound care and physical therapy. Anti-anxiety medications can be used to enhance the effects of analgesics for anxiety related to wound care procedures or appearance changes or fear. It's important to differentiate between anxiety and pain. Other adjunct pain medications are used to enhance the effect of opioids. Example, Neurontin and Lyrica. The pain management plan of care is individualized and includes both pharmaceutical and non-pharmaceutical methods. Non-therapeutic methods of pain management includes relaxation breathing, guided imagery, hypnosis, biofeedback, computerized gaming, and music. Throughout the different phases of burn recovery, continuous physical therapy is important in order for the patient to regain and maintain muscle strength and optimal joint function. Physical therapy is best administered during and after wound cleansing when the skin is soft and bulky dressings are removed. Both passive and active range of motion should be performed on all joints. The patient with neck burns should continue to sleep without a pillow or with their head hanging slightly over the top of the mattress to promote hyperextension. Ensure that the patient is scheduled for occupational therapy for wearing custom fitted splints, which helps to keep the joints functional. Check the splints for pressure points to avoid skin breakdown. PT and OT should be continued upon discharge to home. Nutritional therapy plays a significant role in the outcomes of the patient with major burns as it promotes healing. Large burn injuries that remains open places the patient in a hypermetabolic and highly catabolic state, resulting in an increased caloric need to assist in wound healing. Patients with burns 20% or greater has difficulty consuming adequate calories and protein, also carbohydrate, which is needed for wound healing. If the patient is unable to take food by mouth, example, if they're mechanically ventilated, a small bore feeding tube is placed for enteral feeding. A swallow study should be done after extubation before an oral diet is started. An NG tube may also be placed. All of this for continuous feeding or intermittently in the form of a bolus. Large burn injuries require longer nutritional support, and a duodenal feeding tube is often recommended to help prevent aspiration and allow for feeding up to and during procedures. Vitamins and minerals are often administered to promote wound healing. The patient may lose their appetite and might begin to lose weight. The patient should be encouraged to eat adequate amounts of protein and carbohydrates. Weight loss should not exceed 10% of pre-burn weight. The patient's daily caloric intake should be recorded and weighed weekly to evaluate progress. To prevent infection, proper hand washing remains one of the most effective methods of preventing spread of infection. Prophylactic antibiotics are not recommended because of the possibility of breeding antibiotic resistant bacteria. Testing for positive culture is used. Contact precaution is used by some centers when entering patient's room. Family members and medical teams should be aware of and knowledgeable about standards and adhere to it. In the rehabilitation phase, the patient is now able to participate in self care. This could occur as early as 2 weeks or as long as 7 to 8 months after injury. The goal for the patient is to begin working toward consuming a functional role in society and rehabilitate for any necessary functional and cosmetic post burn reconstructive surgery. Not only is a burn injury physically painful, but dealing with the long term emotional consequences are often difficult. The patient may experience PTSD, body image disorder, anxiety, and or depression. This will require the involvement of mental health professionals. The family should also receive psychological support. There are two components to scarring: discoloration, in which is the new skin or scar tissue, and it will appear flat and pink. Over time, the discoloration will fade. There is contour, which over time the scar tissue becomes elevated and enlarged as a result of tissue hypertrophy. To control these contoured scars and keep them flat, custom fitted pressure garments are used to apply gentle pressure over the area of burn to prevent hypertrophic scarring. The wound should be fully healed before wearing the garment. They should be worn for up to 24 hours a day and for as long as 12 to 18 months. The garment should only be removed for short periods while bathing. The healed area is very fragile and sensitive to trauma. Slight pressure or friction can cause skin tears or blisters. The newly grafted site may be hyposensitive or hypersensitive. The newly grafted skin is usually hyposensitive because of a lack of peripheral nerve regeneration. The patient should be taught to protect the healed burn site from direct sunlight for about 3 months to prevent hyperpigmentation and sunburn injury. Because burn patients may be lacking sweat glands and the newly grafted skin is sensitive to light, you also want to teach the patient about sun protection, such as wearing a sunblock. There are several contributing factors to the development of contractures, including the extent, depth, and location of the burn. Contractures are characterized as a permanent shortening of the scar tissue in the flexor tissue of the joint. Proper positioning, splinting, and exercise to limit the complication is important and should be encouraged. Because the flexors are stronger than the extensors, rehab is focused on extension of these body parts. During the rehab phase, we want to encourage both patient and caregiver to participate in care. We want to teach them the skills necessary for wound care since the patient might go home with open wounds. For example, we want to teach them how to apply their pressure garments to prevent hypertrophic scarring, to medicate 20 to 30 minutes before starting the procedure as it can be painful. I want to teach the patient that they need to contact the burn team and it's important to keep their appointments. If the patient needs home care, it's the role of the nurse to ensure that all the necessary arrangements are made. We need to teach the patient that it is best to shower and not bathe with mild soap and warm water to keep the wound clean. Advise that a water-based moisturizer can be used, and this will help to keep the skin supple. The patient with major burn may require reconstructive surgery, and so we want to provide community resources for support upon discharge. This should also include psychological support. Community resource for burn victims or burn survivors may be difficult to find, but can provide essential social and psychological support. The burn survivor has many psychological and emotional needs. One of the roles of the nurse during the lengthy emotional process of caring for the burn survivor is to be supportive and provide counsel. In order to manage all emotional needs of the burn patient, it is important to assess the circumstances of the burn, the family relationship, and previous coping experiences with stressful stimuli. The patient may experience fear of dying, fear of being able to progress upon discharge, anxiety, anger, guilt, and depression. They frequently experience PTSD, nightmares of the incident, and body image disorder, also hopelessness. These may happen for years. Open and clear communication among the patient and the caregiver and close friend and family, also the burn team, is very essential.